Hi guys, welcome back to the channel, and this video is about a condition known as OEIS complex. So you can see in the video, this is a neonate who is born with the condition known as OEIS complex, and this guy has underwent a massive surgery and was in our neonatal care unit for around 2 weeks. So this video is a summary of what all events this guy has gone through and a small effort to show the workflow which we follow in our neonatal care unit. So this is the condition with which he was born. See, the child has an anterior abdominal wall defect. The green color sac is known as Omphalocele and the red color one is protruded bowel. This is known as cloacal exstrophy. Along with this, he doesn't have a bladder. The bladder is not formed well. And there is an imperforate anus for this guy, and there are also spinal defects. In our case, we have a bifid spine. So these are the problems with which the child is born with. He requires multiple stage surgeries, and in our case this guy has underwent a first surgery and has recovered from all the complications of the surgery and infection. So you can see this is the pre-op photo of the child. The child was ventilated and taken to the OT. There the child was being operated. So these are the intra-op photos of the child. You can see how small his abdomen is. See, this anterior abdominal wall defect is being referred and the bowel was placed inside. So this is the post-op photo. You can see the colostomy and the repair of the bladder which was done, and the midline suture was done. So you can see the erythema and redness on the abdominal wall. So that was the condition with which the baby was transferred to our neonatal care unit. So after receiving the baby, we put the baby on continuous positive airway pressure. Even on continuous positive airway pressure, the baby was developing respiratory distress and the distress was worsening. There was prolonged CRT and the baby was in shock. So you can see the distress, the baby was grunting as well. So we got an emergency 2D echo done bedside. So it was suggestive of TR jet, like the tricuspid regurgitation jet. Usually we don't see it. If we see it, it is a telltale sign of persistent pulmonary hypertension. So in this case, we traced it down and we put a continuous wave Doppler on the TR jet, and we got a right ventricular systolic pressure value of around 49, which we can take it around 50. And if it comes around 50, then we grade it as moderate PPH. So that is the reason for the respiratory distress in the baby. So as this baby also had bilateral lower limb defects and CTEV, there was a difficulty in getting the IV access for the child. So we decided to go with the jugular central line. So as it is, I have made a detailed video on how to place a central line. You can watch the video for complete details of the procedure. So I follow the 3-swab technique and I sterilize the probe, and I follow the same 3-swab technique to sterilize the part at which I am planning to go with the internal jugular vein placement. So I preferred the right IJV, and after sterilizing I always use lignocaine jelly because lignocaine jelly prevents any hypothermic reaction on the child. So after sterilizing and draping the baby, we use USG guided ultrasound, USG guided IJV cannulation. So you can see the bright white spot, which is the tip of the needle which is being introduced, and it is piercing the vein. See, now we can see that the bright white spot is within the lumen. So this is a telltale sign that our cannula has pierced the vein, it has punctured the vein. So after this, we will remove the needle and we will insert the catheter. So this is the video after cannulation, after placing the central venous line, and you can see the baby was being given almost 4 infusions at a time. The baby had hypoalbuminemia, that is, the albumin was decreased because the baby had infection and the baby was in septic shock. There was loss of albumin, and there was hypovolemia, means the blood volume was also decreased in the baby due to decreased albumin. So we were transfusing albumin, maintenance fluid, and due to PPHN we were giving inotropes like milrinone and IV sildenafil. So this was a very complicated situation where we were not able to give much fluid, and we were in a very critical situation. So this was the inferior vena cava of the child. After giving the albumin transfusion, it opened up well, and Then we performed a 2D echo bedside every day, almost every day for the child. so that he doesn't land up into any complication or there won't be any worsening. So you can see the heart function was good, and there was the tricuspid regurgitation jet again. So after tracing the jet, we put the continuous wave Doppler and we got a right ventricular systolic pressure of around 45-46 again. So there was a little bit of improvement compared to the previous value, which we got around 49 to 50. So this was the point when we thought that the baby was responding and we should not leave the baby. But yet there was labile saturations, yet there was fluctuating vitals. The heart rate was fluctuating. It was shooting up to 170, 180 and again coming back to baseline. So even with that, we stick down to our treatment. The subsequent 2D echo images showed a decreasing trend in the tricuspid regurgitation jet. See, now we can see that the continuous wave Doppler, the intensity of the waves were decreasing, and we got a right ventricular systolic pressure of around 40. So there was a decrease in 5 mm Hg of RVSP, and this is the point where we stuck to our treatment. We gave the baby high-end antibiotics, cefepime, colistin, amphotericin B, metronidazole, and we gave even IVIG and pentaglobulin for the baby. So after getting a 40 mm Hg of RVSP, I tried weaning the baby off from continuous positive airway pressure to high flow nasal cannula, and you can see the saturations were maintaining very beautifully, and the fluctuation of heart rate was also stopped. So this was a positive sign for us, and the baby's perfusion was improved. And then we got a 2D echo done again, and this time you can see the intensity of the jet was decreasing, and the right ventricular systolic pressure this time turned out to be around 30. So this is a case in which the baby underwent a surgery, developed sepsis, septic shock, sepsis-induced PPHN, hypokalemia, hypoalbuminemia, hypovolemia, thrombocytopenia and leukopenia. And the baby was lucky enough to be managed well, and we were able to identify all these conditions as early as possible and intervene as early as possible. So after the decrease in the right ventricular systolic pressure to 30, I weaned off the baby to oxygen, low flow oxygen, and you can see how the baby is active and crying well. The peripheries are very pink and perfused. We even secured a second jugular venous line as we needed a second one, and now you can see the baby is active and crying. So now we started the baby on non-nutritive sucking. So this is a small clip showing the baby receiving KMC on his mother, and we started the baby on cup and spoon feeds. As you can see, the baby is taking feeds well. So this is a baby which is born with a congenital anomaly, underwent a massive surgery, developed sepsis, septic shock, sepsis-induced PPHN, hypokalemia, hypovolemia, hypoalbuminemia, thrombocytopenia, leukopenia, and is recovered from everything. Now its lab parameters are improving, and we are planning to discharge the baby soon. So every effort we put on the baby leads to a good outcome and a good life. So this is an example for us. We have learnt a lot in treating this child, and you can see how happily the baby is taking feeds. Thank you.